Good morning all. Today's topic for discussion is multimodality treatment in cholangiocarcinoma. I am Dr. Deepti Sharma from the Department of Radiation Oncology. So as we all know, cholangiocarcinoma are the rare tumors. It constitutes about 3% of the GI tumor and 15 to 20% of the primary hepatobiliary malignancies. The 13% of the total cancer mortality worldwide is because of cholangiocarcinoma. It is common in the age 5th to 7th decade of life. One should always rule out the past history and comorbidities like liver fluke infection, viral hepatitis, and environmental toxins. Also the family history like Lynch syndrome, cystic fibrosis. Cholangiocarcinoma is of two types, extrahepatic cholangiocarcinoma and intrahepatic cholangiocarcinoma. Extrahepatic cholangiocarcinoma further divided into perihilar cholangiocarcinoma and distal cholangiocarcinoma, and in these the patient usually present with biliary obstruction symptoms like jaundice, pruritus, clay-colored stools, and dark urine. Whereas for intrahepatic cholangiocarcinoma, patients are usually asymptomatic or may present with dull upper abdominal pain with weight loss, and on LFT there is increase in alkaline phosphatase. Other than the routine investigations, tumor markers like CA19.9, CEA, alpha-fetoprotein are required. IgG4 is required to rule out cholangiopathies, viral markers, and the imagings which are required are triple phase MRI, MRCP for the tumor staging and bile duct involvement, triple phase CCT, and PET scan to rule out the metastasis. So once the imaging has been done, if the disease is resectable, then the surgical opinion should be taken out before biopsy or ERCP. If it is non-resectable, then histopathology is required. It can be taken either percutaneous route or endoscopic guided. So endoscopic guided biopsy or breast cytology, bile cytology, or EUS guided FNAC from the lymph nodes. FISH is another test with a sensitivity of 93% and a specificity of 100% for the diagnosis of cholangiocarcinoma. NGS panel is required for MSI-H and tumor mutation burden, because immunotherapy has a good advantage in these with high tumor mutation burdens, and then molecular pathology is required. In the FISH test, fluorescent DNA probes are used, and 2 copies of each probe means a normal diploid. So there are 2 copies of each. But if there is gain of multiple probes, like here the blue colors are more than 4, red are 4, so this means that there is a polysomy and it is diagnostic of cholangiocarcinoma. Somatic mutations which are there in intrahepatic cholangiocarcinoma are IDH1-2 mutations, FGFR fusions amplification, BRCA is associated in 15% cases, KRAS mutations and amplifications. Whereas in extrahepatic cholangiocarcinoma, most common is BRCA mutations, HER2 amplification, and KRAS substitution. So these help us to individualize the treatment. Now the treatment, if the disease is resectable, surgery has to be done, followed by adjuvant chemoradiation therapy as per the histopathology. If unresectable, then systemic chemotherapy, radical chemoradiation therapy, or local therapy in case of intrahepatic cholangiocarcinoma like TACE, radioembolization, SBRT. In metastasis, systemic therapy or immunotherapy are best supportive care. Surgery. The goal of surgery is to achieve an R0 resection while preserving the adequate vascular inflow to and the function of future liver remnant. Criteria for resectability are absence of retropancreatic and paraceliac lymph nodes, absence of invasion of portal vein and main hepatic artery, absence of extrahepatic or liver metastasis. The preoperative workup requires the workup for jaundice, whether preoperative biliary drainage is required or not, and if yes, what is the procedure? Evaluation of future remnant liver, role of portal vein embolization, staging laparoscopy, and nutrition management. In distal cholangiocarcinoma, usually patient is directly taken for surgery, but still the indication of preoperative biliary drainage are obstructive cholangitis, And if the tumor is borderline and we are planning for some neoadjuvant therapy, then in that case, preoperative biliary drainage is required. It results in decrease in bilirubin, but at the same time, it causes an increase in the cholangitis and infectious complications. So what is the procedure for biliary drainage in distal cholangiocarcinomas? Either endoscopically guided or percutaneous biliary drainage. So these are the few studies which have showed that PTBD should be avoided as much as possible in the patient with distal cholangiocarcinoma, because it has leads to poor overall survival and higher incidence of celiac metastasis or liver mets. Preoperative biliary drainage for perihilar cholangiocarcinoma. So it is preoperative biliary drainage of the future laminate is required prior to portal vein embolization, as biliary obstruction impairs liver regeneration. Future liver remnant should be more than 20% of the normal liver, more than 30% in case of steatosis, and more than 40% in case of compensatory cirrhosis. These are the two meta-analysis and systemic review which have suggested that for preoperative biliary drainage in resectable perihilar cholangiocarcinoma, one should go with percutaneous transhepatic biliary drainage procedure, because and if we go for endoscopic guided, then there is high procedure conversion rate, cholangitis and pancreatitis, although there is no difference in post-operative survival. Evaluation of the future remnant liver. Evaluation of the future remnant liver can be done by CT volumetry or ICG test or SPECT-CT. An inadequate FLR volume and function poses the patient at risk to post-hepatectomy liver failure, and PVE aims to decrease the risk of post-hepatectomy liver failure by occluding the portal vein to the side of the liver that is resected, causing hypertrophy of the future liver remnant. In this study, published in 2017, they have suggested that not only the future liver remnant volume is important, but also the jaundice at presentation, preoperative cholangitis, and immediate preoperative bilirubin has an impact on the risk stratification for post-hepatectomy liver failure. So they have given points and further classified the patient into low risk, moderate risk and high risk. Patient with a risk score of 4 to 8, they have a high predictive value of 44% of post-hepatectomy liver failure. So these group of patients should undergo portal vein embolization. This study published in 2020, and they have showed that portal vein embolization is associated with reduced liver failure and mortality. In this patient, there are 1600 odd patients in the entire group, with 300 underwent preoperative portal vein embolization, and after propensity score matching, they have found that the rate of liver failure, biliary leakage, intra-abdominal abscess, and 90 days mortality all were reduced in patients who underwent portal vein embolization. Surgery and liver transplantation. So staging laparoscopy should be considered to rule out the occult metastasis. Locoregional lymphadenectomy is recommended. According to the HACC 2018, at least 6 lymph nodes should be dissected out. The majority of the patients with intrahepatic or perihilar cholangiocarcinoma requires an extended hepatectomy with resection of the extrahepatic bile duct. En bloc resection of the caudate lobe is required, and distal cholangiocarcinoma are often treated with Whipple surgery. So in case of intrahepatic cholangiocarcinoma, whether we should go for anatomical resection or non-anatomical resection. So in this study by Anfang et al. In 2019, they have recommended that the patient should undergo anatomical resection, and after anatomical resection, as per these Kaplan-Meier curves also, the disease-free survival and the overall survival was better with anatomical resection. Even after the propensity score matching, the DFS and OS was improved with anatomical resection. It was statistically significant. Role of transplantation in intrahepatic cholangiocarcinoma. So these are the studies which have been published in the last few couples of years, and they have suggested in that in very early intrahepatic cholangiocarcinoma, the 5-year survival ranges from 65% to 84%, with the cumulative risk of recurrence in less than 23% of the patients. Whereas in cases of advanced intrahepatic cholangiocarcinoma, 5-year overall survival is up to 45% and cumulative risk of recurrence is 61%. In case of perihilar cholangiocarcinoma, the approach is use of concurrent chemoradiation therapy by external beam technique, followed by brachytherapy, and then maintenance chemotherapy till the liver transplantation. And in this, this is a study from 12 US centers. The data is collected from 12 US centers, and they have found that the recurrence-free survival in the patient who underwent transplantation at 5 years was 65%. Also, they have found that the patient with small tumor, that is 0 to 3 centimeter, they had a better recurrence-free survival of about 69% at 5 years as compared to 32% in the patient, as compared to 32% in the patient with large tumor, that is more than 3 centimeters. So what should be the technique? By the transplantation or surgery for perihilar cholangiocarcinoma. So this is the data from 10 US centers, and in this transplantation group has 41 patients with was compared with surgery group with 191 patients, and they have found that in the patient who underwent transplantation, there is a good overall survival of 64% at 5 years as compared to 18% in the resection group. So the patient who are eligible for transplantation should undergo transplantation and not resection, because there is worse survival in the patient with less than 3 centimeter tumor and node negative who are eligible for transplantation and underwent resection. Now the prognostic factors and the pattern of recurrence after surgery. In intrahepatic cholangiocarcinoma, the most common factors are resection and lymph node. So if it is R0 resection and node negative lymph nodes, the overall survival and disease-free survival is far better as compared to the patient with node positive or resection positive tumors. In case of hilar cholangiocarcinoma, usually the recurrence is of early recurrence and late recurrence. 1/4 is early recurrence at a cutoff of 1 year, and 3/4 had late recurrence. So in this study, they have concluded that the patient with lymph node metastasis, poor differentiated tumors, increased post-operative CA 19.9 levels, neutrophil to lymphocyte ratio of more than 3, and age more than 60 years, they are all associated with increased risk of early recurrences, whereas Bismuth type 3 and 4, PNI invasion, and poor differentiated tumors, they all are associated with late recurrences. So in hilar cholangiocarcinoma, one should go for a long surveillance, even because studies have suggested that there are chances of recurrence even after 5 years. In case of distal cholangiocarcinoma, the most common site of recurrence is lymph node locoregional lymph node metastasis, and therefore this study has also found that if there is lymph node metastasis, the probability of recurrence-free survival and overall survival is very high in patient with lymph node mets. Overall survival is decreased in the patient with pancreas invasion and age more than 62 years. For advanced disease, the locoregional therapy is RFA or microwave ablation, TACE, TARE, radiation therapy, photodynamic therapy, and systemic therapy. These are the few studies which have been published in last 20 years, and in these studies they have showed that there is a technical success rate of ranging from 66% to 100%, with a complication rate of less than 10%, and median overall survival range from 10 to 16 months. The variation in the median overall survival is because of the change, is because of the multifocality of the tumor and the different tumor size. Also the molecular pathology, which have a role in the overall survival of these type of patients. This is a study published in, as a proceedings in 2021 by Taiji et al. And they have found that percutaneous ablation for intrahepatic cholangiocarcinoma, there is an impact of molecular profiling. So in these 46 patients with 69 intrahepatic cholangiocarcinoma lesion, they have been undergone for ablation therapy. NGS panel was done in 18 patients, and poor prognostic mutations were present in 6 patients. So they have found that the patient without mutation, they had a better local tumor progression-free survival, mean intrahepatic progression-free survival, and mean overall survival as compared to the patient with mutations. TACE can be done by either lipidol-based TACE. So TACE can be done by either lipidol-based TACE or DEP TACE. So again, in these few retrospective case series, the size of the lesion which have been treated with TACE ranges from 2 cm to 11 cm. Most common chemo used is cisplatin and adriamycin, with a follow-up of again ranging from 1 month to 8 years, and the survival, median overall survival from 9 months to 25 months. Similarly, in DEP TACE, follow-up ranges from 3 months to 35 months, and the survival ranges from 9 months to 30 months. So all these, there's decrease in the mean overall survival is because of the systemic pattern of the disease, because there are high chances of distant metastasis even if we go for local therapy. So there is an analysis of meta-analysis of survival, complication and imaging response after TACE. In this there are 16 studies were included with 542 patients. The cumulative median overall survival was 13.4 months. Objective response at the primary site is 76.8%. If we go, if the response assessment is done by imaging, that is as per RECIST criteria, again there is about 76% response, and if it would have been done by M-RECIST criteria, the imaging response would have been increased. 1 year overall survival again in this group of patients is 58%, with the CTCA grade 3 or more reaction in about 20% of the patients. TARE is another modality, although not been done in so many studies. So it's a prospective observational study published in 2019, and there is a median follow-up of with a median follow-up of 13.9 months, overall survival 9 months, and here in this group the CTCA grade 3 reaction was in 8% of the patient, but the median progression-free survival was 2.8 months and median local progression-free survival was 3.1 month. In case of unresectable extrahepatic cholangiocarcinoma, sometimes our intent is palliation of the patient to reduce the bilirubin levels. So in this way, we can go for either PDT with stenting or radiation frequency ablation with stenting. So in this meta-analysis with PDT, with 10 studies, they have found that the patient who underwent PDT and biliary stenting, there is improvement in the overall survival from 183 days to 349 days, change in the KPS scoring after the intervention, and after the intervention the bilirubin level has decreased by 4.23 in PDT and biliary stenting group, but in PDT group there is about 11% chances of photosensitivity. In PDT we usually give photofrin at the rate of 2 mg per kg. It is injected, and after 48 hours the diode with 630 nanometer is being used to target the lesion. The other modality for palliation of symptoms is radiation frequency ablation with stenting, and in this randomized trial RFA and stent was done in 32 patients and biliary stenting alone was done in 33 patients. At a follow-up of 21 months, mean stent patency rate was 6.8 versus 3.4 months with comparable side effects. Also, at 6 months, the survival rate was 97% versus 82% in the two groups, which was statistically significant. Role of radiation therapy. Radiation therapy can be given either in neoadjuvant settings, that is neoadjuvant CTRT followed by liver transplantation, or adjuvant settings in case of R1 resection and lymph node positive disease, and radical radiation therapy for locally advanced cholangiocarcinoma. As per the neoadjuvant CTRT followed by surgery for intrahepatic and mainly for hilar cholangiocarcinoma, these are the two studies which have showed that neoadjuvant CTRT followed by transplantation has a better overall survival, disease-free survival and metastatic-free survival as compared to the patients who underwent chemoradiation therapy alone and not undergone orthotopic liver transplantation. For adjuvant radiation therapy, in the extrahepatic cholangiocarcinoma, there is a meta-analysis from 21 clinical trials, and they have found the better overall survival in the patient who underwent radiation therapy with a hazard ratio of 0.63. Also in the patient with positive lymph nodes and positive metastasis, there is an improvement in the group who had received radiation therapy in the adjuvant settings. In the patients who are ineligible for surgery or any other modality of treatment, SBRT can be done, and these studies have showed that SBRT is an option for intrahepatic as well as extrahepatic cholangiocarcinoma. In majority, it is intrahepatic. The dose given ranges from 25 gray to 60 gray in 5 to 10 fractions, and the local control ranges from 65% to 60% to 95%. Median overall survival ranges from 15 months to 36 months with a CTCA grade of 15 to 20%. This is a study published in 2019, retrospective study, and they have compared SBRT versus conventional chemoradiation therapy and TARE in the patients with unresectable intrahepatic cholangiocarcinoma. So at the median follow-up of 17 months, the median overall survival in the three groups is 48 months, TARE 20 months, and conventional radiation therapy 14 months. So as per these Kaplan-Meier also, the overall survival is better in the patient who underwent SBRT as compared to TARE and conventional radiation therapy, and the two curves for conventional radiation therapy and TARE, they are just overlapping each other. The other modality of radiation therapy is brachytherapy. It can be given for radical purpose and palliative radiation therapy to facilitate the outflow of bile in patients with extrahepatic cholangiocarcinoma. It can be done by ILRT technique, that is intraluminal radiation therapy, in which the tube is placed via the nasogastric way, and then the blind HDR catheter is placed in that tube, and then after planning, the radiation can be delivered. The purpose of this type of radiation therapy is to give maximum dose to the tumor and prevent the spillage and other side effects to the remaining part of the remaining organ at risk. Here are the few studies in which EBRT has been combined with brachytherapy, and these studies have suggested that if the combination of two have been used, that there is an improvement in the median overall survival and disease-free survival. The other mode of brachytherapy is interstitial brachytherapy. In this, the catheters are placed via percutaneous route on under CT fluorescent guidance, and then the plan has been formulated for these patients, and the number of catheters depends on the size of the lesion, whether the large cavity or the smaller cavity. And again, with this type, we can give a higher dose to the center of the tumor with a prescription dose of 20 gray to the periphery of the tumor, and the remaining liver receives a lesser dose. This is a trial study in which 15 patients with 27 lesions has been treated with CT guided HDR brachytherapy, and in this study the median follow-up of 18 months, the median local tumor control was 10 months, and median survival after local ablation was 14 months. Systemic therapy. As per the BILCAP study, phase 3 randomized controlled trial, patients with resected biliary tumor tract cancer can be offered adjuvant capecitabine chemotherapy for a duration of 6 months, and that has been incorporated by the NCCN and the ESCO guidelines also. And in this systemic review and meta-analysis, again, as per the per protocol analysis, the BILCAP trial demonstrated improved overall survival and disease-free survival with adjuvant capecitabine. However, in the intention to treat analysis, the improvement was not statistically significant. The further, the systemic therapy which has to be used for advanced and metastatic cholangiocarcinoma mainly includes combination of gem or cisplatin, FOLFOX, targeted therapy and immunotherapy. For advanced biliary tract cancer, if best supportive care is being given without any chemotherapy, the median overall survival ranges from 2.5 to 4.5 months. Whereas with this doublet chemotherapy, the median overall survival ranges from 11 months to 12 months. So how we can improve the median overall survival in advanced cases also? So Schroff et al., in a study by Schroff et al., which is a phase 2 study, has used triplet based regimen, and with this the median overall survival increases to 19 months with the overall response rate of 45% and disease control rate of 84%. Second line chemotherapy mainly includes the FOLFOX and irinotecan and capecitabine, and the targeted therapy. This will be dealt with by Dr. Namita in subsequent lectures, so I'm not going in detail of this. ILBS data from June 2018 to July 2021, radical radiation therapy has been done in 10 patients. I'm not going in the adjuvant radiation therapy. It was presented by Dr. Pooja last week. So look, in radical radiation therapy, locally advanced tumor was 7 and metastatic 3. The primary site was intrahepatic cholangiocarcinoma 6, perihilar 3, distal cholangiocarcinoma 1. Technique and fractionation size, SBRT, was given in 4 patients with a dose ranging from 25 gray to 48 gray in 5 to 6 fractions. Hyperfractionated RT, 3 patients, dose ranges from 35 to 58 gray in 10 to 15 fractions, and conventional RT in 3 patients. Median age was 58. In our group of patients, there were only 4 male and 6 females. CA 19.9, mean value was 108, ranging from 1 to 840. Neoadjuvant chemotherapy was received by 8 patients for a total of 4 to 6 cycles, mainly gem cisplatin or gem capecitabine. Adjuvant chemotherapy was received by 6 patients. 1 patient has received targeted therapy, that is trastuzumab, for 1 year. And 1 patient has received TACE procedure before radiation therapy. Right hepatectomy was done in 1 patient. Post-radiation therapy response, local effect, complete response in 2 patients, partial response in 4, and stable disease in 4. Here is the Kaplan-Meier curve with a median follow-up of 14 months ranging from 5 to 25 months. Median overall survival is 14 months. 1 year survival is 70%. This is one of our patient with intrahepatic cholangiocarcinoma, Mrs. AG, 56 years old female. There was a large SOL, 10 cross 9 cross 8 centimeter in the segment 2, 3, 4A, 4B, and with the satellite nodules multiple in segment 8. She has received 4 cycles of chemotherapy with GemCape, followed by stable disease, and then hypofractionated radiation therapy to a dose of 55 gray in 15 fraction. This is a color ISO dose of 55 gray. It was completed in May 20. Then she received adjuvant chemotherapy and targeted therapy, that is trastuzumab, because of HER2 amplification till July 21. And this is a PET scan done in August 21, which is suggestive of minimum residual disease at the primary site. So algorithm, if the patient is a candidate for resection, surgery should be done. If not a candidate for resection and with a good performance status, if it is intrahepatic cholangiocarcinoma, then locoregional therapy and systemic therapy. If perihilar cholangiocarcinoma, then liver transplantation if feasible. If not, stent followed by systemic therapy and locoregional therapy, radiation therapy especially, and distal cholangiocarcinoma, stent followed by systemic therapy and locoregional radiation therapy. For the poor performance status patient, one should go for stent, mainly the plastic stent, and best supportive care. Way to go forward, larger studies looking upon the various treatment modalities in different stages will help us to individualize the treatment. For example, in intrahepatic cholangiocarcinoma advanced stage, we can go for systemic therapy, chemotherapy, followed by local therapy in the form of radiation therapy, SBRT, and then continuation with chemo and immunotherapy as per the molecular profiling. So to conclude, biliary cancer is a heterogeneous disease with a very poor prognosis, and implementation of multidisciplinary team approach prior to the initiation of treatment, and treatment should be individualized. Participation in prospective clinical trials is required. So cholangiocarcinoma treatment requires a teamwork. Thank you.